Welcome to the sketchy swim meet. We're about to get started here. Just waiting for the last swimmers to approach the starting blocks. Oh no! The swimmer in lane 37 just took off too early. That's a false start. As long as we're talking about things happening too early, we may as well talk about preterm labor, which is labor that occurs at less than 37 weeks gestational age, which is also why we're in lane 37. The reason we care about preterm labor is that it's the cause of approximately half of preterm births, and we don't want the bun out of the oven until it's fully baked. Preterm birth is one of the main causes of infant morbidity and mortality, and is associated with a number of complications, which we'll symbolize here within lane 37. These include respiratory distress syndrome, represented by our recurring symbol, the RDS shark, intraventricular hemorrhage, symbolized with the recurring red butterfly, this time on the early starter swim cap, necrotizing enterocolitis, symbolized with this black logo over the swimmer's belly, and infant death, represented by this skull. So let's try to prevent these poor outcomes by better understanding preterm labor. The pathophysiology of preterm labor is intricate and not completely elucidated. However, there are some known causes that we'll review here. One of the most well studied causes of preterm labor is infection, which we'll remind you of with these bacteria shaped backstroke flags above lane 37. Common ones are urinary tract, lower genital tract, and intraamniotic infections. Placental abruption, represented by the top of this pool drain abrupting off of the pool's floor, is also a known cause of preterm labor, as the blood is thought to irritate the uterus into contracting. And finally, uterine overdistension, such as seen with multifetal gestation, is the final cause of preterm birth that we'll cover. We'll remind you of uterine distension due to multiple fetuses, with this uterus backpack filled with multiple goggles. If a pregnant woman comes in complaining of contractions or cramping, just like this swimmer is, and she's less than 37 weeks gestational age, then you have to consider preterm labor. While you can't distinguish true labor from false labor on contractions alone, the contractions of true labor tend to be at frequent, regular intervals and get stronger with time. Because it's common to have a pregnant patient come in complaining of contractions, you're really going to want to assess for risk factors for preterm labor when taking their past medical history. One of the biggest risk factors for preterm delivery is a history of preterm delivery in a prior pregnancy, represented by this team record of false starts. Wow, a little less hot off of the starting block next time, okay? Prior cervical surgeries, such as LEEPs and cold knife conization of the cervix, also increase the risk for preterm labor. We'll represent cervical surgery with this knife cutting into the pink cervix shaped bundt cake. A patient would have had one of these procedures if she has a history of cervical intraepithelial neoplasia due to HPV. In terms of a social history, cigarette smoking vastly increases the risk for preterm birth. Coach over here is turning to an age old and not recommended form of stress relief, the old cancer stick. Now, moving on to our objective findings. Your pelvic exam, specifically the digital cervical exam, is going to tell you a lot. We've represented a digital cervical exam with this kid sticking his finger into the pink bundt cake. If the patient is having regular contractions and you find her to be 2 centimeters or more dilated, then she's most likely in preterm labor. Because infection is such a well-known cause of preterm labor, you're going to want to check for any evidence of a lower genitourinary tract infection in all of these patients. We're going to symbolize the labs over here in and around the warm-up section of the pool. They include a wet mount, represented by the splash of pool water on the slide-shaped tiles, a gnat for gonorrhea and chlamydia, represented by this swarm of gnats, a Group B strep swab, symbolized by our recurring galactic baby, who's learned how to swim, and a urinalysis and urine culture, represented by the pee in the pool. Hey, wait, galactic baby? You wouldn't. A short cervical length is another risk factor for preterm birth. so many providers will check a cervical length during the workup of preterm labor. Different guidelines use different thresholds for what constitutes a short cervix, but the upper limit of this range is 25 millimeters, as in a short cervix is one whose length measures less than 25 millimeters. In addition to being a risk factor for preterm birth, a short cervix also qualifies a patient for extra treatment, which we'll go over later in this video. That's it for all the studies you're going to get. Now let's move on to the assessment and treatment. As we just mentioned, if your patient is having regular contractions and she's dilated 2 centimeters or more, then she's probably in preterm labor. If it's unclear whether or not she's in labor, either because she's not dilated or her contractions are irregular, it's important to keep the patient to assess for any cervical change. Usually, a repeat cervical exam is done 2 hours after the initial one, and if any cervical change has occurred, you've got some preterm labor on your hands. Another test that you can do to rule out preterm labor is a fetal fibronectin test, which involves taking a vaginal swab and testing for FFN. Fetal fibronectin is an extracellular matrix protein that's detectable when there's been some separation between the amniotic membranes and the uterus. We've symbolized it over here with this flower shower that has a hummingbird attached, because they eat nectar. This test has a 99% negative predictive value, which means that if it's negative, you can be 99% sure that your patient will not deliver within the next 7 to 14 days. However, its positive predictive value is really bad, so you can't use it to tell you that your patient is truly in labor. The most important intervention that you can do for a fetus that you think is going to deliver in the preterm period is to give it corticosteroids, usually either betamethasone or dexamethasone. These medications are injected into mom and then passed to the fetus through the placenta. Giving a preterm fetus steroids accelerates fetal lung maturity, which then decreases the incidence of respiratory distress syndrome of the newborn. Studies have shown that antenatal corticosteroids also decrease rates of intraventricular hemorrhage, necrotizing enterocolitis, and death. For a long time, steroids were only given to those in whom delivery was expected prior to 34 weeks. But recently, another major study showed that fetuses up to 36 weeks and 6 days can benefit from steroids. What does this mean for you? If you think that your patient is at risk for delivering within the next 7 days and she's less than 37 weeks gestational age, give her and the fetus steroids. Now, how about if her uterus is really contracting and you don't know if you're going to be able to give her the full dose of steroids, since all regimens used have multiple doses? That's where tocolytics come in. Tocolytics are drugs that inhibit the uterus from contracting, and we've symbolized them here with this pregnant woman relaxing on the bleachers. There are multiple drug classes used as tocolytic, which we'll go over in just a second. But in general, these medications can delay labor up to 48 hours and shouldn't be used for more than that. Generally, the upper limit of tocolysis is 34 weeks gestational age. Now, let's go over which medications are used as tocolytics. Nifedipine, symbolized by this knife on a plate next to the relaxed pregnant woman, works as a tocolytic by blocking calcium from entering into the myometrial cells, preventing them from contracting. Terbutaline, a beta agonist, is also used to reduce contractions. We're representing terbutaline here with our recurring do not disturb sign. Indomethacin, represented by these indigo socks, is an NSAID, so you know it blocks prostaglandin synthesis. But it can also function as a tocolytic. However, because it blocks prostaglandin synthesis, it shouldn't be used after 32 weeks gestational age because it can prematurely close the fetus's ductus arteriosus. If there are any other concurrent complications, such as an intraamniotic infection or a non-reassuring fetal heart tracing, then tocolysis should not be used and labor should be allowed to progress. Finally, magnesium sulfate, represented by this magazine on the relaxed woman's chest, is another potential tocolytic. However, it's contraindicated in those with myasthenia gravis. As you may have realized already, magnesium sulfate has a lot of uses in pregnancy. In addition to tocolysis, it's also used for seizure prophylaxis in preeclampsia with severe features. Yet another use of magnesium is for fetal neuroprotection if you anticipate delivery before 32 weeks gestational age. Studies have shown that magnesium decreases the risk for cerebral palsy in this group. Finally, if the patient is GBS positive or GBS unknown and anticipated to deliver soon, she should get GBS prophylaxis in the form of penicillin. We've drawn in this purple pencil pool noodle next to the swimming galactic baby to remind you to do this. Remember how we mentioned that a history of preterm birth puts your patient at a much higher risk for preterm birth in her current pregnancy? If you know your patient has a history of a preterm birth, then you can give her intramuscular progesterone injections throughout pregnancy to try to prevent another preterm birth. We've represented IM progesterone therapy with this muscular trophy, protected by our recurrent symbol for progesterone, the protective dome. This is usually started between 16 to 24 weeks gestational age and is given through 36 weeks gestational age and is only done if she's pregnant with a single fetus. Quick note here. IM progesterone therapy to prevent preterm birth is a hotly debated topic. But for now, ACOG still recommends IM progesterone in women who have had a history of a preterm birth in a previous pregnancy. Now, do you also remember how we mentioned women with short cervixes qualify for additional treatment? Well, no need to wait in suspense any longer, because we're going to talk about them right now. Patients found to have a short cervix, again, which threshold is used varies by practitioner, but the upper limit is 25 millimeters, qualify for vaginal progesterone therapy. Both the timing of the diagnosis of a short cervix, whether or not universal screening is appropriate, and treatment duration are all hotly debated topics within obstetrics, and they're beyond the purview of this sketch. Just remember, vaginal progesterone is used if a patient has a short cervix in order to prevent preterm birth. We've symbolized the relationship between short cervix and vaginal progesterone with this protective dome over the short pink donut. Looks like our swimmers have finished their laps and the race is over. Let's tell that coach to put out his cigarette and come on over here to watch a little game tape. The swim meet was all about early starts in preterm labor, which brings with it the risk of preterm birth and its accompanying complications. Though the exact pathophysiology of preterm labor hasn't been completely elucidated, some known causes are infection, placental abruption, and uterine overdistension. Some risk factors for preterm labor are a history of preterm labor in a previous pregnancy, cervical surgery, smoking, and a short cervix. In addition to the lab assessments we went over, you should also perform a digital cervical exam, which is the piece of info that'll tell you whether or not she's in true labor. If she's dilated 2 centimeters or more with regular contractions, or has cervical change over 2 hours with regular contractions, then you should be very concerned for preterm labor. Tocolytics should only be given to delay labor in order to administer a full dose of prophylaxis, such as antenatal corticosteroids. They shouldn't be used for more than 48 hours and only prior to 34 weeks gestational age. If you're anticipating a preterm birth prior to 37 weeks gestational age, give steroids for fetal lung maturity. If you think she'll deliver before 32 weeks gestational age, give magnesium sulfate for fetal neuroprotection. And if she's GBS positive or unknown, give your patient prophylaxis in the form of penicillin. Finally, IM progesterone is used as prophylaxis to prevent preterm birth if a patient has had a history of preterm birth, and vaginal progesterone is used for the same reason if your patient has a short cervix. And that about wraps up our swim meet. Hopefully, next time, there are no false starts.